Welcome to This Explainer. Okay, today we are taking a seriously paradigm-shifting look at the realities of critical care. We usually view the intensive care unit through this purely clinical lens, right? It's a place of high-tech machinery, complex meds, heroic life-saving measures. It is high stakes, literally, every single second. But beneath that surface of intense clinical precision lies a deeply human experience that honestly often goes completely unnoticed. So we're going to unmask the ICU and explore the hidden human stressors that profoundly impact whether a patient survives and recovers.
Now, I want you to take a second and really imagine a typical hospital setting, specifically an ICU. If you were placed in that bed right now, what do you think would be the absolute most stressful part of it? Seriously, picture it. Most of us instantly think of the environment, don't we? The chaotic rush of the medical staff, those blaring alarms, the stark fluorescent lights. And it's true, ICU noise levels frequently rival a busy highway. It sounds incredibly overwhelming. But what if I told you that the reality of what patients actually experience as their primary stressors is vastly different from what we assume? We naturally assume the environment is the main culprit. The noise, the alarms, the lights. Well, actually, scratch that. Because when researchers actually go on and ask patients what causes them the most distress, they report deeply human existential discomforts. They talk about severe physical pain. They talk about an absolutely unquenchable thirst. They describe this terrifying loss of control over their own bodies and the agonizing inability to just communicate their basic needs. So the focus of our care really has to move way beyond just dimming the lights or silencing an alarm. It's got to address these profound, deeply rooted physical and emotional challenges. Looking closely at the precise physical reality of the bedbound experience, we uncover a whole new layer of distress. Just take a look at the specific stressors patients identify. We see pain, which sure is expected, but look right next to it. Tubes and lines restricting movement. Imagine the pure claustrophobia of not being able to simply shift your weight or scratch an itch, all because you are literally tethered to life-saving machines. Then there's sleep deprivation, and not just from the noise, but from constant medical pokes and prods. We see the total inability to communicate, and perhaps most heartbreakingly, the loss of family roles. You aren't a mother, a father, a provider, or a caretaker in that bed anymore. You are a patient, stripped of your usual identity. These are the real hidden realities of critical care. And here's the thing, these hidden realities aren't just emotionally taxing. They are medically dangerous. This brings us to a really fascinating field of research, psychoneuroimmunology. Okay, I know it's a massive word, but the concept is an absolute game changer. It's the study of how chronic stress and psychological states directly impact a patient's immune function. We actually have the research showing that emotional stressors, like the extreme fear, the loss of control, and that sleep deprivation we just talked about, can directly suppress the immune system, meaning if a patient is terrified and feeling powerless, their physical body is quite literally less equipped to heal. The mind and the body are just intricately wired together in the recovery process. Building on that mind-body connection, we absolutely have to recognize the compounding effects of critical illness. This illness affects way more than just the physical body. It severely impacts a person's psychosocial and spiritual well-being. A lot of patients experience deep spiritual distress and just a total loss of hope. Some even develop severe anxiety and post-traumatic stress reactions, PTSD, especially after prolonged ICU stays or really life-threatening events. And for those who come into the ICU already managing pre-existing mental health conditions, coping becomes exponentially harder. Combine all of this with severe sleep disturbances, whether that's from the illness itself, the ICU environment, or conditions like sleep apnea, and you are significantly slowing down physical healing while drastically increasing the risk of ICU delirium. To really ground this in the patient's reality, consider this specific quote from our source material regarding mechanical ventilation. Many feel frustrated by their inability to speak and the discomfort of the ventilator itself. I want you to take a brief second to imagine the specific terror of being on a ventilator. A machine is literally breathing for you. You have a tube down your throat. You're experiencing all the pain, the thirst, and the fear we just discussed. But you have absolutely zero voice to ask for help, to ask what's happening to you, or to tell your family you love them. The profound vulnerability of losing your voice is, without a doubt, one of the most intense psychological stressors a human being can ever endure. So, how on earth does the medical community address this kind of terrifying experience? Well, this is where highly skilled nursing care becomes absolutely vital. While the mechanical ventilator is a lifesaver, no question about it, it adds immense physical and emotional stress.
The baseline of care here naturally starts with airway safety and preventing ventilator-associated complications. I mean, that's the clinical necessity. But just as importantly, nurses have to facilitate patient communication, even when that patient is entirely nonverbal. They use communication boards, hand signals, careful observation. They are providing vital emotional reassurance, essentially establishing a human connection to anchor the patient through the absolute fear of being silenced. Now, because no single nurse or doctor can manage this immense physical, psychological, and spiritual burden of critical illness entirely on their own, we have to look at the broader collaborative solution. Enter what I like to call the cavalry, the multidisciplinary team approach. This brings together professionals from incredibly diverse backgrounds. We're talking about nurses, physicians, respiratory therapists, pharmacists, dietitians, to manage those really complex nutritional changes we see in the ICU, and social workers. They all converge around the patient, bringing their own specialized lens to work toward one common, unified goal. And when you deploy a true multidisciplinary team like this, you aren't just treating the failing lungs or the heart attack. You are treating the whole person. The respiratory therapist is managing the vent. The dietitian is ensuring nutritional support for healing. The pharmacist is monitoring complex drug interactions. And the social worker is right there helping the family navigate that brutal loss of roles and anxiety. This kind of holistic safety net significantly increases the quality and the continuity of care, which is absolutely critical for patients suffering from complex, chronic, or multi-system conditions. Let's synthesize the most impactful outcomes of this team approach, because the ripple effects are huge. Because every single team member brings distinct expertise, communication naturally improves, and this triggers a powerful domino effect. Better coordination prevents delays in care, which then allows teams to identify and fix broader hospital system problems way more effectively. It allows for the careful prioritization of daily activities so the patient gets exactly what they need, exactly when they need it. And the ultimate result of all this amazing coordination, it leads to the biggest wins of all, a reduced length of stay in the hospital and lower overall healthcare costs. It's a massive win-win for both the highly vulnerable patient and the broader healthcare system. Now, if the multidisciplinary team is a wheel, the critical care nurse is absolutely the hub. They are the central pillar of this entire environment. In the high-stakes setting of the ICU, nobody works in a silo. Success relies entirely on teamwork and mutual trust across all those disciplines we just mentioned. But it's the nurse who is right there at the bedside 24/7. They are the ones constantly synthesizing the information from the physicians, the pharmacists, the therapists, and actively translating all of that into moment-by-moment patient care. To effectively act as that hub, a nurse requires a highly specialized toolkit. First, they need deep biocultural and psychosocial knowledge to truly understand diverse populations. This allows them to make incredibly accurate assessments and plan personalized interventions. Next, they have to seamlessly rely on and collaborate with the broader healthcare team in a state of interdisciplinary interdependence. And above all else, they must be master communicators. They've got to clearly share incredibly complex medical info, listen closely to really subtle patient cues, and build trusting relationships with patients, highly stressed families, and team members to ensure the care is safe and coordinated. We've covered a lot of ground in this explainer today, unmasking the true reality of the ICU experience. We've seen that the real stressors aren't just the beeping machines, but the deep existential challenges of pain, silence, and feeling totally powerless. And we've seen how a multidisciplinary team anchored by incredibly skilled critical care nurses steps up to treat the whole person, not just the disease. So I want to leave you with this thought-provoking question to ponder as we wrap up. Knowing the hidden, deeply human stressors of critical care, how does this holistic, human-centric approach change your view of what true healing actually looks like? It definitely moves far beyond mere environmental comfort, doesn't it? True healing demands that we courageously address human vulnerability right head-on. Thanks for joining me for this explainer, and keep questioning, keep learning.